Welcome to the University of Washington Tracheotomy Care Training video, module on accidental decannulation. By the end of this video, we anticipate you will be able to list the emergency equipment needed for patients with a tracheotomy tube, describe the steps to assess accidental decannulation and ensure adequate oxygenation and ventilation during accidental decannulation, and describe methods for recannulation. Decannulation refers to the situation where the trach tube comes out of the tracheotomy tract and may no longer be functioning properly. If a patient depends on their trach as their airway, this can represent a medical emergency since the patient may not be able to breathe. In addition, the trach tube can also be partially out of the airway such that it actually blocks an airway that might otherwise be open. When you are concerned about decannulation, you must first inspect the tracheotomy tube in the stoma. The flange should be resting up against the skin. If the tracheotomy tube flange is away from the skin and you can visualize the cuff or the end of the tracheotomy tube, the tube is most likely not in the trachea anymore. Another reason to suspect decannulation is when a person is able to speak more loudly and clearly than before. This can occur because air is no longer able to pass through the trach tube and is instead passing through the voice box and nose and mouth. If you suspect the tracheotomy tube is no longer in the trachea, then you should call for help. First, assess the patient to determine if they are moving air through their native upper airway. Look at their color and how hard they are working to breathe. If they appear to be breathing normally, then you can reassure them that they are doing okay. If your family member is not adequately breathing through their native airway, it will be necessary to assist them. This should be accomplished by two of the following methods. First, hold a sterile 4x4 gauze or other object over the stoma while you ventilate over the nose and mouth with a resuscitator bag and mask. It may be necessary to have another healthcare provider assist with this, as it can be difficult to coordinate by yourself. If the native airway is not appropriate for bag or mask ventilation, such as the case with a patient who has suffered severe facial trauma, you may place the mask over the stoma site and attempt to ventilate through the stoma. If the tracheotomy tube is less than 7 days old, you should wait for the other providers who placed the tube to reinsert the tracheotomy tube. This is because the tract has not fully formed and the risk of placing the trach into the soft tissues in front of the airway, i.e. a false passage, is very high. Once oxygenation and ventilation have been assured, you should prepare to replace the tracheotomy tube. You should replace the tracheotomy tube with the spare tube from your emergency supply. First, check the integrity of the cuff by inflating the cuff and checking for leaks. You will then deflate the cuff and position the patient for reinsertion. The best position to reinsert is for the patient to be flat with their neck hyperextended. You may place a blanket or pillow under their shoulders to help with this. Don't overextend the neck if the patient has a confirmed or suspected injury to the upper spine. Insert the obturator into the trach tube and apply lubrication. Applying firm pressure and keeping your thumb on the obturator to keep it in place throughout the insertion process, slide the tracheotomy tube into the trachea. Stay sutures may be in place on the trachea. If they are, hold them apart to provide counter-traction to the reinsertion of the tracheotomy tube. Once the tracheotomy tube is in place, remove the obturator right away so the patient can breathe through the trach, and reinsert the inner cannula if the trach tube has one. Assess for proper placement by checking that air is passing easily through the trach tube and that the patient is breathing comfortably without noisy breathing, implying turbulence from the blockage. Healthcare providers might listen to the lungs for bilateral breath sounds. Other methods to check for proper placement would include end-tidal CO2 or colorimetric CO2 detection. In this module, we provided an overview about the importance of identifying patients at risk for accidental decannulation, how to assess patients for suspected decannulation, and how to reinsert a tracheotomy tube.